Hello, everybody. Today, let's learn about the applications of fluorescent in situ hybridization or FISH in solid tumors. And today, I will be discussing this topic from the perspective of a pathologist. Now, FISH can be performed on two kinds of specimens. The first are the hematological or the suspension specimens, where we can either use peripheral blood, bone marrow aspirates, pleural fluid, or cerebrospinal fluid, or even fine needle aspirates which have been suspended in a fluid medium. The other option is to use solid tumors or tissue specimens, where we use formalin fixed paraffin embedded tissue sections, which are cut to a thickness of 4 to 5 microns. There is a basic difference between these two kinds of specimens. When you use hematological specimens or suspension specimens, the nuclei are usually intact, which means the FISH signals are clearer and there are fewer artifacts on the slide. On the other hand, when you cut sections of 4 to 5 micron, remember that the nuclei are approximately around 7 to 8 micron, and therefore the nuclei are going to be sliced through or truncated. Therefore, the FISH signals here might be lost. The second problem is that microtomy may lead to certain sectioning artifacts like folds, which means your signals might not always be clearly present, and sometimes you will find that they are not at the same level. Because of this, we usually keep our thresholds and cutoffs lower for hematological specimens compared to those of tissue specimens. I will explain more about cutoffs as we go ahead. Let's look first at the principle of FISH in solid tumors. It is basically the same as what we use for hematological specimens, but there are certain additional steps. So when you use formalin fixed paraffin embedded tissue sections, you first need to dewax the specimens with xylene and then treat the sections with pepsine to digest the proteins. The next step is the same, where you have to denature both the target DNA and the probe DNA. Because we want to turn the double-stranded DNA into single-stranded uh, DNA. Now, for this, we heat both the target DNA and the probe DNA, often at 75 degrees Celsius, to create the single strands. Now, once you have a single-stranded DNA from the probe, it will bind to the complementary homologous sequence in the tumor's DNA, and it is a very specific binding. Now, first we denature the specimen. Heat allows us to separate that double-stranded DNA, but after that we cool down the solution to allow the probes to hybridize properly and bind properly uh, to reform the double helix. After this, we need incubation to allow binding, and then there are subsequent stringent washes to remove all the unbound or non-specific probe sequences. So this post-wash, you have a buffer which removes all the unattached probe strands, and only the specifically bound complementary probe DNA is bound to the target DNA. So there are fluorescent tags on the probes, and this allows you to visualize the locus specifically. We also use DAPI as the nuclear counterstain. It gives a blue color, and this allows us to visualize the nuclei under a fluorescent microscope against that blue background. So the usual workflow for solid tumors is that you look at the morphology under HNE under the light microscope. On the basis of that, you decide what the immunohistochemical stains are that you need for arriving closer to the diagnosis. And based on the immunohistochemistry, you call for FISH for whichever target you want to detect. And if FISH is equivocal, only then you go into next generation sequencing. You will find that most labs still manage to retain their fish labs even when they have higher molecular techniques such as next generation sequencing. And why is that? It is because fish still has certain advantages. And the biggest of these is that fish allows you to visualize the abnormalities or the alterations spatially within the specific tumor architecture. What do we mean by this? Molecular technologies such as PCR or NGS require DNA extraction. This means we lose information about where exactly the alteration exists. However, if you are doing fish on a solid tumor, you have the H&E section and you can compare it with where the signal is in the fish section. So you know whether the abnormality is present in the tumor, in the stroma, in the normal tissue, you know exactly where it is. So fish preserves the geography of the tumor, which DNA extraction doesn't. The other advantage is that when a tissue goes through formalin fixation, remember there are going to be DNA crosslinks formed. There's going to be chemical modification in the nucleic acid. And all of this means that DNA extraction might not be all that easy. Secondly, if you have bone biopsies, what happens is that you go in for acid decalcification, and that again destroys the tumor, the DNA. Um, in our specialty in pathology, we are expected to make bigger and bigger diagnosis with smaller and smaller tissue. This means when you do DNA extraction, the quantity of DNA might not be insufficient. Um, so old blocks which are almost there for 20 years or 30 years, they may also get different kinds of degeneration happening there. So all of these samples are problems where NGS frequently fails because the quality of DNA or the quantity of DNA might not be sufficient. Whereas even if you have a few intact nuclei, it is sufficient for your fish samples. So fish can tolerate all the hurdles that are brought about by formalin fixation, by decalcification, um, or by small pieces of tissue. The third advantage is that when you know what you're looking for, if you know we are looking for a target such as HER2 or EWSR1 or SS18, in that case, fish is a much cheaper and a quicker option compared to NGS. And it is also highly accurate to detect specific copy number alterations and structural rearrangements, as we will see in the cases ahead. So the four clinical questions which can be answered by fish. One, is there amplification? And this is a usual routine procedure we carry out with HER2 samples in breast cancer when they are equivocal on immunohistochemistry. Is there a pathognomic characteristic fusion as we see in synovial sarcoma in SS18 translocation? Is there a targetable rearrangement? Like if you have specific treatment for ALK rearrangements and if you can demonstrate ALK, the patient gets a specific treatment. And as we already saw, whenever IHC or morphology is borderline or not contributory, then fish might give you the answer, like in breast HER2 or in ALK borderline cases. So this is the approach we take. Do immunohistochemistry first and assess if the protein is detectable and if IHC is equivocal, or when you want to demonstrate that gene amplification is the diagnostic primary key, you can either do fish here and then if this morphology is not specific or if you want to demonstrate multiple genetic alterations, you will escalate to doing NGS. And if you want to assess the global architecture as we saw in our previous video on karyotyping, there we will consult the karyotyping. So to summarize, when should a pathologist choose fish first? One, when the diagnosis hinges on gene amplification, like in HER2, where a tumor is equivocal on morphology and where the clinician is hankering for a diagnosis. When a translocation is pathognomic or when it defines the entity, like in Ewing sarcoma or in synovial sarcoma, when IHC is unreliable, for example, when you have ALK clones which are variable, or when NGS is unavailable in your setting or the turnaround times are very long, where the patient can't wait, then definitely choose fish first. Before we go ahead, I'd like to give you a brief introduction into the commonest fish probe patterns used in diagnostic pathology. The first probe pattern are seen when you know what the specific translocation partners is. And there we use a dual fusion probe. Now, in this case, say for example, we take a BCR-ABL translocation and you want to detect whether this translocation is present here. So you will tag the BCR with say a red probe and ABL with a green probe. And in a normal cell, you will find two BCR probes and two ABL probes. So two red signals and two green signals. Now, when you have a fusion of BCR and ABL, like you see in chronic myeloid leukemia on the Philadelphia chromosome, you know that BCR and ABL are going to be placed together. So this is a schematic diagram, so it doesn't show very well, but otherwise you will see a yellow signal, which is two fusion signals. Two yellow signals will be seen wherever you have a specific translocation happening. So is this clear? In the normal, you will see two red and two green. In the abnormal, you will see two yellow signals. Contrast to this, and it's completely opposite case, which is where you know that there is a rearrangement of a gene. Say, for example, you know there is an Ewing sarcoma EWSR1 gene, but it has multiple partners. So it can bind with any partner of the ETS family of transcription factors. So the usual one you get is when EWSR1 binds with FLY1. Now, otherwise, there are other options also where this gene can bind with, can have a partner which is ERG. It can be ETV1 or ETV4. Now, if I wanted to go in for a dual fusion FISH probe, I will need multiple probes, which is a very expensive option because I will need a separate probe for FLY1, I will need a separate probe for ERG. So instead of that, I want to detect only if EWSR1 is showing any kind of rearrangement. So what do I do here? I use a, two probes which bind to either side of the EWSR1 gene. So on the upstream end, I use a red probe, and on the downstream end of the gene, I use a green probe. So normally these two signals will overlap and you will see two yellow signals in a normal cell. Whenever a rearrangement happens, and it could be with any of the partners I mentioned, you will have the two signals move apart. And this is called a break apart signal or a split signal. So what you're seeing here is that these two signals have moved apart because now the EWSR1 gene has undergone some kind of a rearrangement. Now what is important is that the distance between these two signals should be more than two diameters, two signal diameters at least, to call this abnormal. So this is what we use in break apart probes. This is completely opposite to the dual fusion probes. I hope this is clear now. Coming to the third pattern, which is the amplification probe. Here, the normal gene will have two red signals, but to compare this, we use two centromeric probes. So the green signals are the centromeric probes. So in a normal cell, you have two gene signals and two centromeric probe signals. Now, like in this case, you are seeing large clusters of the red signals, which means that there is amplification of this probe. So this is for copy number variations. You can see the amplifications are deletions, and we usually use a ratio between the gene signals versus the centromere signals. So like in HER2, we use CEP17, which is the centromeric probe on chromosome 17, and in well differentiated liposarcoma, we use CEP12, which is the centromeric probe on chromosome 12. So these three are the important patterns that you see with um, the fish signals. So how do you determine cutoff thresholds? Is an important factor to remember. Every lab determines its own cutoff thresholds. So one thing you can do is you can take a section of normal tissue, like if you're doing breast, take a section of the normal breast, compare it with the tumor. You establish the baseline signal rates on the normal tissue, and these are the false signals. And this will help you to count the normal nuclei to define the limits of detection. Now, what we usually do is we take the mean number of signals seen in the normal tissue, and we use three standard deviation. Um, and that means we account for around 99% of the false signals. So anything above that. So if you are getting maybe 1 to 2% here in the normal tissue, your cutoff will be around 3 to 5%. So anything above that will be considered abnormal. There are standard guidelines for different kinds of tissue given in literature. So usually for each tissue they are different. You could say counting 20 to 60 nuclei per probe is important. Uh, that is to ensure your statistical reliability. Look at the different guidelines for whichever tissue you are determining the cutoff for. We already talked about break apart probes, where how you count makes a huge difference. So the split signals, they should not be too close. They must be at least more than 2 signal diameters apart to be counted. So in clinical application, like if you look at the NCCN guidelines, you will say that the ratio of HER2 to CEP17 in breast is more than 2, that is considered positive. In ALK for lung tumors, where we use break apart probes and not amplification probes, it is said that 15% abnormal nuclei are to be considered positive. In synovial sarcoma, SS18, we use a break apart probe, and here because it's the pathognomic signal, we expect at least more than 50% of the cells to show you these split signals. That is considered adequate. So you have to look at which tumor and what the guidelines are. Sometimes you are in the borderline zone or in the gray zone. So what you can do is, one, ask a second person, second expert to review the case, and then come to a consensus. um, the second procedure is you can do extended counting. If they are telling you to count 60 cells, here you go on to 100 or 150 cells and then see what the count, whether the counts change. And if it's still borderline, it is important to reflex test to NGS. Um, you have to be very good at uh, determining whether something that you're counting is correct or not. I've already talked about the issues with thin sectioning and truncation of the nuclei. So pseudo aberrant patterns you need to be sure about. So determining these thresholds are critical for accurate decision making in tumors, and every lab will determine its cutoff for each tissue separately. So let's go through some case scenarios where we can see the application of FISH. The first case is the usual, a 52-year-old woman who had an invasive ductal carcinoma, grade 2. Her FISH was ER positive, PR positive, but the HER2 was equivocal 2 plus. So you see that a normal 3 plus HER2, which is positive, must show uniform membranous staining all around the nuclei to call it 3 plus. However, what we got in this case was um, faint intensity of the staining and not slightly patchy. So this is 2 plus on equivocal, and in that a normal cell will show you two orange probes for HER2 and two green probes for CEP17. Now, if you look at these other signals here in the cell, the orange probes are much more compared to the green probes, and this means that the ratio of HER2 to CEP17 is more than 2, and the average HER2 copy number is more than or equal to 4. Now, I want you to go in and look at the NCCN guidelines because it's a complicated topic. It will require a whole separate lecture in itself to talk about how you determine HER2. But this is the basic way that we approach it by look for the ratio and then determine amplification. But there are some issues here. Look at this case. You will see that everywhere you find only one green signal. So this is a case of monosomy 17, therefore the centromeric probe shows only one signal. Similarly, in this case you are seeing three green signals. So this is a trisomy 17 in the centromeric probe. So therefore the ratio of HER2 to CEP will be affected in cases of monosomy and trisomy, and this is a flaw with this case. So to summarize this, um, this is how you look for HER2 or CEP17 amplification. Whenever you get an equivocal IHC of 2 plus, it mandates FISH testing, and the pitfalls are when you get trisomies or monosomy of the chromosome 17, where the CEP17 will show you false results. So it is important to do HER2 because you have a targeted therapy in transducer. Let's go to the next case. This is a case of a 58-year-old man with a large, deep retroperitoneal fatty mass. Um, and we saw this case, I think, in the karyotyping video. So the morphology showed mature adipocytes with fibrous septa and atypical stromal nuclei, very few of them. So the problem here was, is this a lipoma? Is this an atypical lipoma? And given the age and the site of this mass and the size, it was around 8 centimeter, I think. So is this a well differentiated liposarcoma? We did IHC with MDM2 and CDK4, but it was weak and patchy, especially because these cells are far and few, and this is under high power. So in all these cases, what is important is that let us look at this fish example where the MDM2 is red and the CEP12 signal is green. Now here you are seeing that these MDM2 signals are large because a lot of these signals are clustered in one area. So MDM2 amplification in this case helps you to identify a well differentiated liposarcoma, and this amplification is most useful. So whenever you have a deep-seated lipoma, especially in the retroperitoneum, this requires you to do MDM2 FISH, and it's more reliable than IHC in this context, and it prevents undermanagement clinically. Case 3 is a 16-year-old boy with a lytic lesion in the diaphysis of the femur. Um, on histology, we found small round blue cell tumor, uh, and we've seen this case already in the karyotyping video. The immunohistochemistry was a CD99 positive case, but this is not specific, and several other tumors can be positive for CD99. So we went in for FISH. Now, again, remember that EWSR gene can have multiple partners. So in this case, we prefer a break apart assay where in the normal, this is the fuse signal, we use um, the two fluorescent probes at the two ends of the gene, which is normal. And when there is a gene rearrangement, the two probes move apart. So you get this kind of a break apart assay, which confirms the presence of Ewing. So as you can see, these split signals are seen in more than 80% of the tumor nuclei here, and therefore we have a diagnosis of EWSR1 rearrangement. But remember, EWSR1 FISH rearrangement will support the diagnosis of Ewing sarcoma, but it does not define it. The reason is EWSR1 rearrangements can also be seen in desmoplastic small round cell tumor, where this gene has a partner that is WT1, or if the partner is ATF1, then it is a clear cell sarcoma. So in these cases, um, FISH will support your diagnosis, but if you want to have a confirmatory diagnosis, you need to escalate to an RNA fusion panel of NGS to carry the Ewing sarcoma like fusions. So going up Going on to case 4, this is a 32-year-old woman with a deep mass around the knee. This is a spindle cell proliferation. So, given the site, it could be a synovial sarcoma, but because it has hemangiopericytoma-like vessels, we could also think of a solitary fibrous tumor. It could be a leiomyosarcoma. It could be a fibrosarcoma. We don't know. So, uh, it could also be a spindle cell carcinoma. So the immunohistochemistry was for TLE was positive. Um, it was strong diffuse positivity, but it's not very specific here. So we need to see if there is a translocation between chromosome X and 18, which is diagnostic of synovial sarcoma. And in this case, we used a dual break apart fish probe where these hybridized to the chromosome 18q11.2. Here, one probe was used proximal to the SS18 gene, and the orange probe was used distal to the SS18 gene. So, a normal nucleus will show you a fusion signal, whereas a translocation will show you one separate orange signal and one separate green signal. Now, SS18 break apart probes, we saw this again. It shows you that rearrangement. TLE is supportive, but it's not very specific. So, this SS18 break apart fish is definitely um, positive, and it shows you definitely that this is a synovial sarcoma. And this is a knee, so it was not so important here because you know that knee is a common site for synovial sarcoma. But if the location was something like the kidney or the head and neck, or the morphology, if it was more ambiguous, then this would definitely be very useful. Coming to a case of the lung, which is a 49-year-old non-smoking woman um, with a stage 4 lung adenocarcinoma. Now, these kind of young women, non-smokers, are usually positive for ALK, uh, but the ALK here turned out to be equivocal. Now, I'm showing you pictures to show how we report fish. So in this case, because it is a break apart probe, what we see normally is two fusion signals, which are yellow in color. Now you have to look for different signals here. Now here you are seeing a split pattern, but the question we have to ask is, this is a short split pattern where the distance between the two signals is almost less than 2 signal diameters. So this is a case where either it could be an inversion kind of rearrangement, then this could be possible, or it could simply be that the chromatin has stretched so that the signals appear apart. So this is something you don't count. A short split pattern is something you avoid. A long split pattern is the correct one, where you can see the distance between the two signals is more than 2 signal diameters, and this is the correct signal. You could also get a far away split pattern. One is here and one is here. And here you are seeing a deleted split pattern where after rearrangement, probably one signal was lost. And this is not a rearrangement, it is simply polysomy where you can see multiple fusion signals. So, the other thing we have to see is that I told you that for ALK, you must see at least 50% to call it positive. What do you do if you get something like 12% split signals, which is below your 15% cutoff? You can report it as negative, but you're not sure. Don't discard this if it's a borderline result. One thing you can do is an extended count. So count more cells. And here you're seeing 18%. So 18% is more than 15%, but it is still borderline, right? It is so anything between 10 to 20% borderline fish positivity of the split signals carries a very high risk of misclassification, and you do not discard a borderline result. It's important that you go in for NGS because there is a highly effective targeted therapy here. You have crizotinib or alectinib, and both of this should not be denied to the patient, and therefore you will have to go in for NGS to confirm this ALK fusion. Now, coming to the last case, this is a 18-month-old boy with a large adrenal mass. There was no problem with the histology. We already saw it in the karyotyping video, that this is a poorly differentiated neuroblastoma with intermediate mitotic karyotypic index. And this is how you look for the uh, MYCN amplification, which is seen. These are the normal diploid signals, one red and one green. But here it is full of these amplified signals. So MYCN amplification directly corresponds to the double minutes that you saw in karyotyping, and this will classify the disease as high risk and which will alter the therapeutic approach. So you might not have fish NGS in a low resource setting, and their fish usually works. So this is a summary of all these cases, and take a screenshot if you want to, because these are the common sites which you all must know about. So there are several errors which can be recognized across the pipeline, and these can be classified as the pre-analytical, analytical, and the post-analytical errors. It is important in the pre-analytical phase to look at the fixation of your tissue. The ideal fixative is 10% neutral buffered formalin, and this should be there for 6 to 72 hours. When you overfix the sections, the tissue, that makes a huge difference. The second problem is with the cold ischemia time. Make it a point to train your clinicians and the nurses in your OTs to record the time when the tissue was taken out of the body and when it was dipped in formalin. So that cold ischemia time, it is, if it's more than 1 hour, it affects the signals. Especially with bone tissues, if you're going to use acid for decalcification, this denatures the DNA, and the signals are faint and there is a lot of autofluorescence. So for fish, we prefer EDTA for decalcification. It takes a little longer, but it is much better than using either um, for formic acid or nitric acid. Coming to the analytical phase, it's important that the digestion with pepsine is adequate. It should not be too less or should not be too more. Inadequate dewaxing or um, increase in the number of in the time for digestion both affect the quality of fish. The humidity during hybridization, if you don't give enough time for the probes to bind, that makes a difference. If the stringent wash is not maintained and done at the right temperatures, that is a problem. And air drying at any stage causes interferes with the fish signals. What you need to remember here is in the post-analytical phase, it is important to realize that there are defects with nuclear truncation. I told you how the sections, nuclear sections might lead to the split signals being seen too far off. So avoid counting bias in the weakly hybridized areas and use the right cutoffs. And you cannot make a diagnosis just based on your fish signals. You have to integrate with the morphology. Most failures in fish are not because of the probe. They usually are because of how the tissue is handled, how it is fixed, how it is processed. So, as I said before, fixation makes a huge difference. Um, Fixation allows cross-linking of the proteins and the DNA, and it stabilizes the DNA. And it's important that neutral buffered formalin is used, and that should be at the pH of 7. Now, whenever you have underfixation, DNA damage occurs. When there is overfixation, you will not get the proper signals from the fish probes. Um, and when the pH is acidic, then DNA degradation occurs. Cold ischemia time is the time between removal of the specimen and fixation. It is important here um, because from the time of removal of the specimen from the body, enzyme degradation starts occurring. And if the cold ischemia time is above 1 hour, DNA degradation is going to occur. Tumor cellularity is important, that you select sections which have large areas of the tumor. especially in the breast, do not use sections with duct carcinoma in situ. DCIS sections will usually be FISH positive, and we do not report on DCIS sections. Use sections from the invasive tumor. Both over digestion and under digestion makes a difference. When the sections are not digested properly, the devac the devaxing is not properly done. Both of these can interfere with the fish signals. Now, air drying artifacts are also important because they interfere with your fish signals. So at each stage where there is air drying, the DNA is going to be affected, and you will get lots of abnormalities. How you use the probes is important. These probes are fluorescent probes, so they are temperature and light sensitive. So always store them in a dark place and at cold temperatures, and to avoid it repeated thawing and freezing. So all of that leads to false negative signals with the probes. And some tissue has their own fluorescence, like melanin and large areas of necrosis. They have their own autofluorescence, and these will interfere with the counting of the signals. So we've already talked about these, the technical problems, the interpretative problems, and the selection of the specimen. Here are some practical rules for the microscopist. Always check the tumor percentage before you start counting. Check if you are looking at the tumor area or the normal area. The sample size matters. So look at the guidelines for the tissue that you are examining, and typically 20 to 60 nuclei are adequate depending upon these guidelines. Do not succumb to bias by scoring only the heavily or the weakly hybridized areas. And we've already talked about this distance metric. Confirm a true split signal by seeing whether the distance between them is more than or equal to 2 signal diameters. So how you submit your report is important. Every solid tumor fish must document the exact probes that you have used, how many abnormal nuclei have you counted, the number of cells in the percentage, the patterns that you have used. Are you using a break apart probe? Are you using a fusion probe or an amplification probe? The laboratory cutoffs and internal controls utilized. What is your final classification? Is it positive, negative, or equivocal? And interpret with the morphological findings and advise more tests if you have to. So it's important that you integrate fish with other modalities, like in ALK, you will confirm it by fish or NGS. If you have a sarcoma, fish will confirm the fusion, but if you want the exact partner gene, like you saw in the Ewing sarcoma case, you will have to go in for NGS. If you have an equivocal IHC in HER2, fish is mandatory according to the NCCN guidelines. For MDM2, fish is better than NGS for amplification. But if you have ambiguous tumors, you have to correlate between your karyotype and morphology also. So synergy is what defines modern oncopathology, while FISH remains an indispensable rapid and spatial tool for solid diagnostics. It is important that you never interpret FISH in isolation. You will look for the artifacts and avoid them. Always correlate with morphology. Always let your specific clinical question dictate your probe selection. Also, the modern standard is that we use a combination of morphology, immunohistochemistry, FISH, and NGS, and all of this will bring us to the correct diagnosis, which we owe our patients. Thank you very much. Please wait for my next video when it happens. Thank you.